But I have discovered that everybody from very educated people, including physicians, they often do not know some of the basics of what is happening in our world when it comes to health reform. So what I'd like to talk to you today is what are the trends, what is really going to drive a reform of our healthcare system. So I'm going to talk about health reform, and I'm going to talk a little bit about Obamacare. So we all know this is a trend that's been unrelenting. This is what families spend on health care. It's up to $20,000 a year. That includes both the family premium and your out-of-pocket costs. Been rising 6 to 8% a year. We know that in the last 3 or 4 years, it's dropped down from 8 to 10% to around 6% because of probably the recession and because of uncertainty over health reform, people putting off procedures thinking they'd have insurance later. But now with the rise of advancements in cancer chemotherapy and genomics, it's expected that the prices or cost of health care is going to resume its rise. We know that a lot of people, including the major employers in the United States and around the world, this is not a U.S. problem, this is a world problem. Every country, Western country, is dealing with these same issues when it comes to health care. Employers believe that a third of what we spend on that $2.7 trillion a year is waste. We heard a lot today or yesterday at our meetings about no evidence for this treatment. We heard about protocols. You heard Dr. Clark mention the Choosing Wisely campaign. All that is to try to identify and avoid waste. So bringing it back a little closer to home, let's not talk about waste. Let's talk about variation in care. Because this is really dogs those people that pay for health care. So, you know, of course, I work for the North Mississippi Health System, big system. We have 7 rural hospitals, a big 600-bed hospital, about 6,000 employees. We're a major player. So we have a good relationship with Blue Cross. And I asked them one day, they wanted to share some information with me. So this is in 2011. These are the joint replacements, hip and knee, that were done in Mississippi to Blue Cross subscribers. And when you see this data, it's sort of stunning because the average cost ranged from a low of $12,500 for that hospitalization to $50,000. You had some hospitals that had a readmission rate, again, this is an elective procedure, a readmission rate of 100% within 30 days. Other hospitals had 0%. You had a length of stay, for example, the length of stay of a hip replacement in our hospital is 2.2 days. But you can see that in many hospitals, the length of stay, average, elective procedure, is 7 days. And I bet no one knows this when they're having a knee replacement or a hip replacement in Mississippi, or I dare say anywhere else, because these statistics, we didn't have them as a hospital. It was Blue Cross that gave them to us. But how would you like to be the one knee replacement that was done at some hospital in Mississippi in that 1 year? So this is the kind of information, it's like, wow, help us understand this. Was there opportunities to improve our cost, to improve our readmission rate? But this is what everybody's asking. So because there's 950,000 hip and knee replacements done in the United States each year, and they're about $30,000 a piece, you all have heard around the country of hip and knees going to Virginia Mason, hip and knees going to Scott and White. Lowe's contracting for this, Walmart contracting for this. Well, in Mississippi, the same thing's sort of happening. Mississippi Blue Cross, they're a dominant player. They said, okay, we're going to adopt a national program. It's called the Blue Distinction Program. It came into play last fall. It goes into full effect this coming January 1st. So they said, okay, we have 400,000 subscribers for our indemnity products in Mississippi. How many hospitals and doctors do we need to take care of all those 400,000 subscribers? Well, they did the calculations and they come out with 4 hospitals and doctors. And so these hospitals fill out 47-page survey about quality and cost and board certification of their physicians and infection rates. I mean, incredibly exhaustive survey. And you're not guaranteed you'll get it because they only need 4. But we're one of the 4. And Blue Cross says we need to make sure that we have access around the state. But on January 1st, if you're in Columbus, Mississippi, and you want to have a knee replacement, you're insured by Blue Cross, you cannot go to the Columbus Hospital. unless you want to pay for it out of pocket. In fact, that whole orthopedic group now that's down in Cumulus is trying to figure out, wow, what do we do? And you can see the politics and the issues, but this is what's going to be happening with all high-volume, high-cost procedures as we go forward. We'll talk about that a little more. And it's not just joint replacement. We're talking about elective spine surgery. We've gotten the Class Blue distinction for both of those. There's a blue distinction for bariatric services. There's a blue distinction for all cardiac services. You're basically taking every one of the most lucrative, profitable, whatever you want to call it, service lines in a hospital and putting them into the center of excellence concept. More about this in a minute. So the blue distinction thing was only kind of the beginning of a broader discussion in Mississippi. And I use Mississippi because it's a good example of the Southern conservative culture, mostly made up of small physician practices. And as we in the South, we figure we're kind of traditionalists when it comes to how we deliver health care. These new concepts aren't going to work in Mississippi. Well, or Alabama, or Texas. Well, 10 for-profit hospitals owned by HMA sort of come down the eastern border of Mississippi, and Blue Cross says, you know, you already charge too much at these hospitals. 4 of them we're going to give a contract to, 6 of them we're not, because 4 of them, the citizens of Mississippi have to have geographic access. So we'll put 4 of them in the network, we'll keep 6 of them out. And of course 6 of them, those hospital administrators, those local politicians, and those employees start having pickets about how citizens are being denied access to health care because Blue Cross won't put these hospitals in their network. And the governor, the Republican governor, who fights with the Republican insurance commissioner over whether or not to expand Medicaid, and we have a Democratic attorney general, so it's really interesting. But the governor says, Blue Cross, you have to include everybody in your network. Well, of course, the governor has no power to do that. So the judge blocks, and this is last couple weeks, so the judge blocks Bryant's Blue Cross move, and then Blue Cross says, you know, we're not going to stand here and put up with this. They start launching full-page ads throughout the whole state saying, you know, if you want us to tell you the truth about hospitals and what they cost, count on us. We'll do that. It says it's not about drama. It's not about negative ad campaigns. It's not about politicians. It's about the rising cost of health care. So this is what you're going to see repeated in so many different variations around the country. So these are the ads, very powerful ads, not backing down. Let's move back into the sort of the generalities of health care in the United States. It's kind of phenomenal that 1% of patients absorb 20% of all health care resources in the United States. End-of-life care, people with chronic conditions. Boy, and when you look at 5% of all individuals absorb 50% of health care cost, where do you think our focus should be? Our focus should be on managing chronic conditions, addressing behavioral health needs, doing a better job with end-of-life care. Well, we'll get to that. But that's where the opportunities are. So you're saying, well, is this simply a period in time in which politicians are bringing up this health care debate? Or is this something different? Is this a repeat of the HMO era? Well, it's not. Because for the first time, you have so many powerful players that are on the same page with some common themes. So you have payers and employers pushing the risk back down to you guys. They're pushing it down to the people who can control the risk, manage the risk, who can prevent the infections, who can prevent the readmissions, who can prevent the hospital-acquired conditions. They're saying, you know, guys, we can't pay you just for all these things that you choose to do if we don't have any control. So we're going to put the control back into your hands, and there's going to be financial incentives and disincentives attached to that. You know that almost every hospital system all over the country is consolidating to some extent. In Mississippi and Alabama, we know that there's probably 30 to 50 rural hospitals that are not going to be able to survive unless they change what they are. I mean, is it really so unrealistic to keep a hospital open that has an average daily census of 5 patients? We need to figure out another way to use those rural health care facilities and take good care of those patients. But you have intensifying production pressures on all of us. Employers are figuring it out. They're going to higher co-pays and deductibles, so they're saying, okay, we're not going to choose. We're going to let our employees make some of these tougher decisions. So you have the American Hospital Association, almost the exact same thing. We've got to align the hospitals. We've got to utilize evidence-based practices. We've got to develop integrated information systems. Then you have the National Business Group on Health. You heard from Helen Darling last year in Nashville. We need to reward based on outcomes. We need to change our options. We need to provide employees with information on providers and hospital qualities. These are all the major players. You have some people that are getting so vocal about this. This is Andy Grove, perhaps one of the finest CEOs in American history. He built Intel from nothing. He says the healthcare industry plays a gigantic game of blind man's bluff, keeping patients in the dark while asking them to make life and death decisions. The odds that they will make the best choice are negligible and largely depend on chance. Patients need to have data, costs, medical histories. So this is what we're seeing, and this is what the payers are embracing. We haven't mentioned Obamacare yet. If you talk to healthcare CEOs, people that run hospitals and large integrated healthcare organizations, and they're saying, is this just another blip in the radar? Aren't we going to go back to normal fee-for-service? Volume's the name of the game. No, this one's for real. We're on the verge of a shift from volume-based to value-based. This is the deal that every big hospital administrator deals with. I make money off of fee-for-service. I may agree that bundled payment is where we need to go, but there's this big hole here that says, how am I going to get paid and support the organization while we figure out this shift? Do I want to be on the bleeding edge, the leading edge, or the trailing edge? My ocean liner has to become what and by when. And I have a real problem with how Medicare is changing regulations so fast and furious that we can't even decipher them, much less help our providers understand them. The market's just not just stressed, but increasingly hard to predict. I mean, we don't know how many patients are going to be in our hospital next year because we know there's this wholesale push to outpatient care. So when you talk about planning and strategy and resource allocation, this is what every healthcare organization in the United States is asking themselves. If you ask doctors or do a poll from these healthcare CEO execs, sort of where their physicians, what kind of payment model they will be working under within their large integrated healthcare systems, you can see that that dark blue piece, fee-for-service, is rapidly diminishing over a relatively short period of time. It's funny when you talk about, if you watch Jay Leno or some of these shows and they ask people questions about what do you know about this and that, people generally don't like healthcare reform. But when you start asking them about pieces of healthcare reform, the answers are sometimes a little different. So if you ask them about health reform, they say, I'm not so in favor of health reform. If you ask them about the individual mandate, and this came from a May 2013 study, they say, I'm really not supportive of that either. If you ask them about Medicaid expansion, they say, yeah, we're kind of supporting that. And if you ask them about the idea of going to an exchange and being able to pick your own insurance product and your deductibles and your prices and your providers, they say, yeah, that's pretty cool. In fact, that's how we do every other insurance product we buy. If you ask them sort of in the new health care law, now we are talking a little bit about Obamacare, if you ask them about some of the consumer protections, such as denying coverage for pre-existing conditions, the restriction on raising premiums, or refusal to cover conditions, basically less than half people even know these things are in play. I mean, were you talking about sick people, Republicans, Democrats? They just, when you have this huge, monstrous change, and so many of us are so uninformed about what we're really talking about, then we're left to the mercy of the Fox, the CNN, the MSNBCs, who are going in doctors' lounges 24 hours a day. They are paid, they get their marketing to inflame, to put sound bites out, to attract your attention, to polarize. That's how they measure their success. It's no wonder there's so much angst over all of this. And one of those things in our organization was my leadership, my boss, didn't allow us to talk about ACOs up until the last few months. Mark, ACOs will never come to the South. There's no sense in talking about this delivery model. Well, ACOs, as presented from Medicare, probably a hard sell. But ACOs as a general concept, they're way out of the barn by now. What is an accountable care organization? And we talked about this at one of our SMA council meetings 2 years ago. It's like, boy, this is just not going to work. Again, small physician practices just aren't suitable to ACOs. So ACOs are considered a real game changer by many of the players. And as you can see, while we talk about Medicare ACOs, right now 30 million people are already in ACOs, and most of them are commercial. They're not Medicare. If you talk about the Medicare ACOs, these were the ones that were originally put out there. But if you talk about commercial ACOs, they're exploding. And guess what? Who's forming most of the commercial ACOs? It's not the payers, it's not the hospitals, it's you guys, it's the doctors. And they're doing them in different niche areas. So you have an ACO for cancer care in Florida. Florida Blue, Baptist Health, and Advanced Medical Specialties, a physician group, get together and form an ACO. We've already talked about the Blue Distinction, which is an ACO-like development. You're talking about if you're having a knee replacement in Tennessee as of a year ago, 4 groups in Tennessee were given bundled payment program by Blue Cross. So you had Campbell Clinic in Memphis, you had Vanderbilt in Middle Tennessee, and you had Knoxville Orthopedics. Those physician groups got together, worked with Blue Cross, bundled payments, didn't even include a hospital. They said, okay, now we got all the business. You hospital come to us, and we'll deal with you from a physician's perspective. Back to my area, my boss saying, Mark, ACOs will never happen here. One day, one of my cardiologists says, hey, Mark, you coming up Thursday to the meeting? There's a meeting. Yeah, there's a group from Oxford, Mississippi coming down, and they have a new company called Accountable Physicians of North Mississippi. Why would I care about that? It's because if all my primary care doctors in our huge system sign up with this ACO, they can't sign up for ours if we ever build one, because primary care physicians can only be in one ACO. This stuff is what's happening. This is what we need to know about. These are the kind of organizations and phenomena that we need to be familiar with. As of September 2013, there are over 370 ACOs in the United States, with another 150 being developed. If we stopped right now with the number of ACOs, they could service half of our entire population. Now, let's switch gears a little bit and talk about large employers, the ones who are really driving health care reform. Politicians may bicker. Medicare may do this. The employers, it flows directly to their bottom line. They're the ones making the changes. Employers are taking bold and assertive steps. This is, can't read that, but employer health insurance costs grow at an unsustainable rate. They figured that the ACA or Obamacare was adding 1 to 2 percentage points to their overall health care cost. And this is right out of that employee bulletin. Evidence continues to mount that fee-for-service delivers, that fee-for-service health care, that should be value-based health care delivers better value at low cost than fee-for-service. That's my mistake. Nearly 40 million individuals will receive health insurance through private exchanges. Okay, so we've heard about all the government exchanges. What's this private exchange piece? Employers are not blind to the risk that offering lower value benefits could undermine them in the talent markets. And this is another fallacy. You know, we're the only country in the entire world where some of our citizens get insurance through employers. In no other world is health insurance tied to an employer. How did that happen in the United States? Because after World War II, there was a freeze on wages because of rampant inflation. Employers still needed to attract good talent. So they said, hey, why don't we add a health insurance option or benefit, which back then was very inexpensive. But they could add it within the context of a wage freeze. And that's how it began. But you know how hard it is. Some people do not change jobs because they fear loss of insurance coverage. Sometimes they don't take a job because they don't offer insurance coverage. It restricts the movement of individuals. And again, we're the only country in the world where we tie insurance to employment. And employers don't necessarily want to be in the business, but they still want to attract good people. And if they have to offer health insurance to do that, they will continue to do that. So employers, some of them are reformers. 41% of them are really getting into health care value programs. About a fourth of them are piloting sort of new programs. Only 15% of them are saying, we're going to keep our health plans about the same as they are now. And this 11% moving to defined contribution where possible. Probably many of you all, when you had your first jobs, you signed on with an organization or a group, and you signed up for retirement benefits, right? And you knew that you could, at any point in time, you could get a little calculation that when I retired 25 years later, I'd get a retirement benefit of $525 a month. Well, of course, employers, to guarantee you $525 off in the future, they had to estimate interest rates, growth on investments, all kinds of stuff. And they said, how do we do all that? So 20 years ago, the retirement systems in this country moved to defined contribution, the 401k, the 457, the 403, the IRA. We're just going to give you a certain amount of money, and you figure out the retirement investments. That way we can predict our costs going forward. This is where healthcare is going to go with employers. And then there's that, you hear about all the employers exiting the health insurance market. These are large employers. Very few of them are actually saying we're going to stop providing insurance for our employees, but they are saying we're going to look at it differently. So some of you saw the headlines here. Walgreens shifts workers to private health exchanges. No small deal. Walgreens is 160,000 employees. And so now Walgreens employees will join IBM employees and Lowe's employees, and they'll be able to go to a private exchange. That's, incidentally, they're being put together by the people who did all the consulting for the business companies, the Towers Watson, the Accenture, the Mercer. They're building all these private exchanges. And they say, here, you can choose among 20 different plans. You can choose family, individual. You can choose a deductible, just like we do other insurance. And what Walgreens is doing, it said, next year we're going to give you the same amount of money that we paid on your behalf to insurance companies this year, and we're going to index it to the inflation rate so that we're not just abandoning you, we're still giving you the resources, but you can go out and buy your own policy. Oh, and by the way, if we lay you off or fire you, it's still your own policy. That's sort of an innately appealing concept, I think, to many people. So it allows for more options. If people can afford more out-of-pocket costs, they can make that choice. They're expecting within a very few years for participation in these exchanges to triple. So I'm thinking, I've heard this before. Well, back when I was a vigorous Republican for George Bush Sr. and Ronald Reagan, I was a big contributor. Jefferson County Medical Society in Birmingham said, hey, Mark, can you come present this concept called medical savings accounts? So I went back in time a little bit later than that. I went to the Eagle Forum, very conservative publication, 1996. 1996, so almost, quite a few years ago, healthcare is a major domestic issue. The system of having your employer own your insurance policy is bad government policy. The correct solution is to move toward a system in which individuals own their own health insurance. Individuals should be afforded the same tax treatment as corporations. And of course, the new exchanges embrace all three of those highly conservative ideas brought to you in the late 80s and early 90s. But it always depends on how it's couched in the news. So if you're Walgreens, you're saying, the company, you're saying, thank God I can make a budget for next year. I can control the cost of my health care just like I can my pharmacy, my labor, my marketing. If you're a Walgreens employee, you're saying, thank goodness I can still keep my health insurance if I lose my job. I can pick my own plan. The employer's still helping me out. But of course, and realize That may have been sort of a result of Obamacare, but not really. The ad, Obamacare is killing traditional employer-sponsored health insurance. Walgreens and IBM. But if you read a little bit down the second paragraph, it says, and this is a good thing. But when you just read the ad, if you just look for the soundbite, if you just look for the bold print, you're not going to get the full picture. So here's the growth in private exchanges. That's how this is from Accenture, how quickly they're supposed to grow. They will outstrip the public exchanges that you've been hearing about very quickly. And by 2017, 18% of the American public will purchase insurance through exchanges. 83%. So while this huge phenomenon is going on, again, we're back to who in the world is educating these people? Us. 83% of consumers have no idea what this exchange concept is. Is this an opportunity for physicians, physician leaders, and organizations like ours to maybe, no matter what political side you're on, to better inform folks? Are you aware of the new health insurance marketplace? Now, this is now back to Obamacare and the new insurance. Well, the uninsured seem to be particularly uninformed, but pretty much no one's really informed about the new insurance marketplace. Let's talk about let's talk a little bit about Obamacare and about these exchanges. And let's go to a health insurance exchange in a state where the governor decided this is a good idea and we're going to do this and we're going to do this on our own, and realize that, like in Alabama, Blue Cross and the health care providers, they asked the governor to set up a private health exchange. And, he chose not to, fine. But that added an additional cost to Blue Cross and the payers because the federal exchange was more expensive to participate in than a state and local exchange. So here's the Maryland exchange. And, this is only in 1 week period. It's up and running, didn't have any problems. Again, Maryland's kind of a small state. But in a 10-day period, first 10 days, 217,000 visits, 26,000 accounts set up, 1,200 enrolled. And when you say, well, tell us about the people who enrolled, well, a lot of young people, which is sort of the goal. Now, Maryland's a different state than many of our states, probably many highly educated, employed. And we say, well, what were the insurance? Let's go to some of the other states, the southern states, and we go to those exchanges. Now we're talking about the government exchanges, the federal government exchanges. What are the premiums on those? And I checked out each one of these. And again, this is family coverage, mid-level. I pay right now, my wife and I and family pay $1,300 a month for Blue Cross of Alabama. Well, the platinum plan on the Alabama exchange is $825. I mean, the gold plan. And what I'm seeing is, at least at first blush, this looks like it's less than what I'm paying now. And so there may be more nuances to this. But then I read Blue Cross headlines in Alabama that said they've lowered their rates 16%. And why did Blue Cross of Alabama lower their rates 16%? It's because, oh my gosh, this exchange is going to introduce competition into our state, and we want to maintain our market share, so we're reducing our costs 16%. If you go to the exact plans, so you have, this is Blue Cross of Alabama, no subsidy, the highest quality plan, platinum, for your family. Humana and Blue Cross, $900 and $1,100. That's less than what I'm paying in Alabama. It's less than what I'm paying in Mississippi. If you look at, well, the deductible is a good question, and it varies, but it can be up to $6,000 or $8,000 for a family deductible. But what's important to realize about the platinum plans is that insurance, inpatient care, is covered at 100%. And that's what most people are frightened about when it comes to health insurance. They're not really worried about the small things. They're worried about having an accident, going into a hospital, and emerging with a $100,000 bill. That's what really scares people, especially young people. So these are just some more examples. It took a minute on that website to get that information. This was the headlines out of the Montgomery Advertiser magazine, Blue Cross Blue Shield of Alabama, early winter. Right now, let's move to a little bit different topic, Medicaid expansion. You all familiar with this topic? I'll admit we represent a large healthcare organization. Last year, our healthcare organization provided $90 million worth of indigent care. We have a budget of roughly $1 billion. We get disproportionate share payments that represent $30 million. And it was with considerable, still, angst that our governor is choosing not to expand Medicaid, because we have a 65% market share in 24 counties, so patients, whether they have insurance or not, are coming to our ERs and our clinics, and we're going to care for them. So said, well, southern states or states that don't have a lot of resources, realizing that Medicaid makes up, on average, 25 to 30% of a state's revenues go to Medicaid. And when they go to Medicaid, they can't go to education, they can't go to other important things that our citizens need. But we said, well, the argument is, Mark, even though the federal government is going to match these funds 9-to-1, at the end of the day, we don't have the one. There's not that much money in our budget, and there may not. But if you ask all the hospitals in Mississippi, would you pay a Medicaid tax of $1 to get $9 back? The answer would be, give me that deal 1,000 times over. And so now you're seeing a lot of governors sort of rethinking some of this. And in fact, if you look at what states might be giving up, and again, I'm sure you're detecting my bias at this point, but if you look at what states are giving up in terms of not taking on Medicaid, the blue is what a state would spend over the next 10 years to expand, and the green is what the federal government would match it with. So Texas, that has 1.5 million uninsured individuals, low-income individuals, is giving up $90 billion. Those are millions over the next 10 years in federal matching funds.
I thought the matching funds only lasted for 2 years.
Great question.
I've read this.
Yeah, okay. It's matched, I think, 98 first year, 95 second year, 93 the next year, and then for the next decade, it's a 9-to-1 match. Federal state. And of course, in Mississippi, we already have a net inflow of federal monies. For every dollar that goes out of our state to the federal government, $3.50 come back in.
But the government borrows all that money.
Well, that's another question.
40%.
That's another question. But you raise a great thing. Is that if you ask John Q. Public how this matching works, most of them wouldn't have known. They think it falls entirely on the burden of the state as we go forward. And again, I'm not saying which way is right or wrong, but let's get a common understanding of what's actually out there. So, health officials, this is what's happening in Texas. You remember I said that figure was $90 billion. This is a headline a few days ago. We're going to close hospitals if we don't get some of these funds. By refusing to participate in Medicaid expansion, this is from, I think, the CEO of Memorial Hermann, the state will leave on the table $100 billion over the next decade. So Ohio, the Republican governor of Ohio, a couple weeks ago, he said, you know, I can't take this. He says, we're going to have to figure it out. So he said, we're going to have to change our position on Medicaid expansion. And sure enough, he did. He said, I cannot ignore this economic booster shot for our hospitals, for our Chamber of Commerce. And that was a quote. That's out of the New York Times, October 21st, just last week. So the health insurance exchanges, whether you're talking about private or government, will be a huge transformation in itself. I saw Jay Leno, and I put his email address up for YouTube address. I saw Jay Leno a few nights ago, and he is out doing his interviewing, and he asked the question, what plan do you support, Obamacare or the Affordable Care Act? Woman number one says the Affordable Care Act. Question is, what is it about Obamacare that you don't like? I just think there's a lot of holes in it, and it needs to be revamped. I think it hasn't been thought out. I don't disagree with the last statement. It hasn't been thought out. Believe me, When it came out, we needed to change 40% of it when it first came out. But again, we have to be educated about the issues. Obamacare and the Affordable Care Act are the same thing. And this went on for each person he interviewed. Obamacare 101, what's already in place. No denial due to pre-existing, children eligible until 26, essential benefits, all these things are already in place. It's a multi-year phase-in. People said, what are the essential benefits? Those are the major essential benefits. Probably the biggest thing to take away from this is there's a renewed emphasis on providing for wellness and preventive services. Every insurance plan, no matter what deductible you might choose, has to pay for certain preventive and wellness services. Let's talk about another thing that causes some angst for doctors and also received some impetus from the Patient Protection Affordable Care Act, and that was the increased use of mid-level providers. Unprecedented demand for family docs and nurse practitioners as Obamacare emerges, and the idea is, oh my gosh, if everybody's going to have Medicaid coverage or insurance coverage under Obama, we're going to be overwhelmed, and our healthcare providers aren't going to be able to handle this. Well, I don't disagree with that, but I'm just not sure what changed, because these people were still out there before. They weren't getting care in our doctor's office. They were getting care in our emergency rooms. We're spending $80, $90 million a year, half of which is probably for inefficient care. It's like, okay, what's the big change here? So the demand for physicians and nurse practitioners is pretty interesting. This is a top 20 most requested physician services this is the Merritt Hawkins 2013 review. They're a huge national recruiting firm. Family medicine's number 1, internal medicine, hospitalists. But look on the top 10 here now. Nurse practitioner and physician assistant. First time those two broke into this physician search survey. Okay, so what's really new? Is something really changed about the role of nurse practitioners and the emergence of nurse practitioners? Well, no. For the last 25 years, their numbers have been increasing exponentially. So again, what's the big change? Now we often say to physicians, we'll say, well, you know, I don't think my patients are going to see a nurse practitioner. They don't like to see a nurse practitioner. Well, I think almost every specialist I know in Birmingham and Tupelo especially, they have nurse practitioners in their office. Cardiologists usually have 2 nurse practitioners per doctor. And I know that my 2 80-year-old very conservative parents love seeing the nurse practitioner because that's the one who answers their questions, who will see them on time. But that nurse practitioner is not doing what the cardiologist is doing. They're doing 2 different things. So this is from Forbes magazine. Again, this is just a little while back. Forbes magazine said, to answer the question from their perspective, will patients see nurse practitioners? They said, if you call your primary care office and you have the option between nurse practitioner and primary care physician, the doctor, which one do you want to see? And they all say the doctor. And then if you ask them the next question is, well, you can see the doctor in a week, or you can see the nurse practitioner tomorrow. They'll say, oh, I'll see the nurse practitioner tomorrow. So it always depends on how you phrase the issue or the question. We talked about Virginia Mason, Walmart picking Virginia Mason for the specialty care. We've already talked about that. We've talked about Walgreens from one perspective, but now doctors, especially in rural communities, think that Walgreens is going to become a competitor for primary care services. Walgreens is wanting to partner with healthcare providers to reduce readmissions because they have people like our last speaker, pharmacists, who really understand a lot of this stuff, who will explain to patients about their medications, who will see if they're taking their medications, who will see if they're getting refilled, thus potentially eliminating perhaps the single major reason that patients are readmitted to hospitals. Who would have thought? Who would have thought that any of these types of relationships would have happened even 5 or 6 years ago? Who would have thought a major employer could persuade all their employees that if you want a knee replacement, you have to go to Seattle? That's the kind of stuff that we need to be thinking about and crafting and directing and participating in. If you look at Toby Cosgrove, Cosgrove is an exemplary physician. He is the CEO of the Cleveland Clinic. He believes that where we're going is going to be a really hard, rocky path, but we have to go there. You probably heard announcements over the last couple of weeks, Cleveland Clinic's having to reduce their operating costs by $330 million. He says that's the way healthcare is going, let's get to it. You heard Dr. Clark this morning talking about Choosing Wisely campaign. Why can't physicians develop evidence-based guidelines in very common areas of treatment, not the government, not the Cochrane Society in Europe? Why can't physician specialty societies in the United States step up to the plate and say, when is a test really indicated or not? Perhaps helping with this tort reform issue, establishing standards of care. Well, the Choosing Wisely campaign has grown. Again, he mentioned, Dr. Clark this morning mentioned 5 things for each specialty. That grew from 3 specialties. Now there's 20 specialties participating. There's American College of Physicians, American College of Cardiology, American College of Radiology, and 17 more. But if you ask physicians, many of them, have you ever heard of this? Do you use these things? The answer is largely no. If you had been at the AMA meeting last summer, and if you were at the organized medical staff section, you would have heard of this incredible presentation from physicians and a government agency as the centerpiece presentation, and OMSS stands for Organized Medical Staff Section, the doctors. And this was a very detailed presentation, but the title says win, 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 how physicians, hospitals, patients, and players can all benefit from better payment and reform delivery. And what he was basically saying in that is, you know, we'll pay you more to do the right thing. But if you're going to continue to do everything, if you're going to do a CT scan on every patient that comes into your ER with abdominal pain, who's afebrile and has a normal white count, we're just simply going to reduce your reimbursement by 25%. But if you can say, listen, we're going to be smart about how we use technology, I dare say there's an opportunity to get paid more for doing well. So let's talk about cancer care in Tennessee. Tennessee Blue Cross says, you know, if you provide oncology care and you'll agree to use evidence-based protocols, mostly based off the NCCN guidelines, we're not asking for our protocols, but you pick the evidence-based pool you want to use, and you agreed to have navigators and palliative care services and survivorship services to help address the end-of-life issue, we will pay you more, significantly more, to take care of our subscribers. And that's what, in fact, the West Clinic enjoys, is a very robust reimbursement schedule because they've done these things in Memphis. So I updated this last night. How many have heard the new SGR proposal that's out there over the last couple days? Okay. Now you've heard a lot of the themes I've talked about in this talk. And now this should spark some degree of optimism among all physicians. The proposal is sort of rough right now, but basically what it says we're going to do away with the SGR, and we're going to put a 10-year pay freeze for MDs. First line doesn't sound too good. But then it says, if you're willing to simply participate in some alternative payment models, maybe a bundled payment, episode of care, we'll give you a 5% annual bonus every year for the next 7 years. Even after that point in time, we'll guarantee you at least a 2% annual increase. And if you choose to simply maintain your fee-for-service practice and style, we'll guarantee you a 1% annual increase over the same time each year, 2016 to 2021. But we want to incentivize you for coordinating patient care with multiple conditions. Remember, the multiple conditions is that 1% up there that absorbs so many of our resources. And we want you to implement protocols to avoid inappropriate care, choosing wisely, what Dr. Clark talked about. These things all tie together. Right now, the AMA is very, very supportive of this early proposal that has both Republican and Democratic support. It's going to cost $195 billion over the next several years, but $195 billion over a period of years is nothing compared to a $3 trillion annual cost of health care. Because at the end of the day, it's not physicians being paid that are eating health care costs. We could double your pay and it wouldn't really affect health care costs, because right now you're only 5% of health care costs. It's what we do with our pens that's the rest of the health care piece. So this is the news that came out yesterday, and I think that's good for all of us. And then there's that last final sort of argument that we never want the SMA to stand for this. I hear so many settings, especially when it's really maybe physicians are tired. They're called upon to do so many things these days. We ask doctors to pursue irrational documentation approaches. We ask them to take call. We ask them to see an increasing share of uninsured patients. We put incredible demands on our physicians. And when they're tired, many of them will say, you know, I'm just going to tell my kids, don't ever go into medical school. Well, that's unfortunate, because I think many of you all have really enjoyed your careers and will probably do the same thing over again. And the fact of the matter is, we're incorrect. The challenge now in medical school education is, my gosh, there's so many young people want to go to medical school now, we can't handle the demand. We're opening up osteopathic schools all over this country to try to meet that demand. Students are willing to pay or borrow $50,000 to $60,000 a year to go to some of these schools. Our challenge in Mississippi, as we've enlarged the university's medical school class from 100 to 150, is that when they finish, there's no graduate medical education positions for them. They have to go out of state. And of course, as we all say, drop government spending, drop Medicare spending. Well, in some ways, we're saying drop graduate medical education funding. So we've got to figure out new ways to pay for graduate medical education. That's a great thing for us to be pursuing. Let's all of us figure out new ways. And when we talk about this, this is one last little thing that came out in New England Journal of Medicine 2 days ago. Let me go back one. This is an interesting graph. It's the first time I've really seen it out here. But this is medical students graduating with, say, a $200,000 debt. And what do they make in terms of their average income? So you can see that over the years, from 1996 to 2010, that ratio of debt to income has gone up. But when you look at some of the actual numbers, you're saying, wow, let's say an orthopedic surgeon there, his average debt, say of $200,000, is roughly 25% of his annual salary of $800,000. You know, you got to put some of these things in perspective. Is that some of our specialties are paid a tremendous sum of money, and that debt-to-income ratio. What about other professions? What do they face? Well, here's another graph that was in there. Do other professions have student debt burdens that may not be offset by future incomes? Well, right now, people who choose to go into veterinary medicine have the toughest debt burden, and then optometry, pharmacy, law, and then you get down to the physicians. So, you know, it's sort of a shared burden. It's not just doctors. And if we want to keep health care costs down, we've got to figure out how to manage this medical school burden. And is it possible for us to guarantee young physicians $1 million the first year as they come out with a GI fellowship? I don't know. But there are proposals out there to say, how do we reduce the cost of health education? How do we get young men and women into their careers quickly? And how do we avoid this age creep problem when all of our doctors are getting older? Well, there's proposals for 3-year medical schools. There's a proposal to not expand a medical school class until you have graduate medical positions available. There's a proposal to link them together so that maybe when you go into that 3rd-year medical school, you've already got your residency position guaranteed. But all these things are things that you all, can be involved in. and we don't want government solutions to these things. We want physician solutions. So it's an exciting time. New York Times, October 27th, what if Obamacare works? Healthcare is going to be more expensive, more subsidized, more comprehensive. But as you can see from the exchange piece, the American people are now getting really tuned in to what's happening in healthcare. Agree with Obamacare or not, they're now becoming more price sensitive. They're now going to ask you more questions. How well you perform is now going to be on a website. And those are the things that we can all, as physicians, help craft. Because this is sort of new ground for all of us. And believe me, I do believe that physician engagement will really make a difference in shaping whatever we really want. So thank you very much. Appreciate your time. And really thank you for being here for the conference. I hope everybody enjoyed the conference. I thought it was really excellent. I want to thank Luke and the SMA staff for really a job well done. So thank you very much.